So I'm Tom Balcezak. I'm the Chief Patient Safety and Quality Officer at Yale-New Hospital. And beginning early in Safe Patient Flow, worked closely with a number of the other members of our management team to start the project here. We really recognized the need to put together all of our capacity creating strategies into one project. And Carpedia was the group around which we organized a lot of those efforts, and Carpedia helped us tremendously to organize those efforts. They did so in a way that was very consistent with the way we approach operational improvement, and they also were very respectful and helpful in accommodating the culture of Yale-New. Starting with direct observations, many hours of direct observations on the direct care units and also in the support areas, and then using heads-up displays and flow maps and other visual tools. It was really compelling, the vision that they created for how we could improve flow at the organization. To top it all off, we also created a secondary oversight committee, which eventually now has morphed into our Safe Patient Flow Committee. The observations process was really extremely helpful. While time-consuming, it did a couple of things. First of all, it allowed the folks on the individual units or the individual areas that were affected to see that we were out there actually hearing the voice of the customer. And then some of the observations that were made were pretty eye-opening, because the managers and the line staff themselves would tell the observers, mostly from Carpedia in the beginning, and then later on observers that were trained by Carpedia that were our own employees, would really tell those observers exactly what was going on and actually give some insight into how some processes worked and how some processes didn't work. So it gave, I think, a real face to the project at the line staff level. I think the observations gave you data, and in many of the instances where we would need to institute method changes, there was not hard data. There was not metrics that looked at time frames from one to another, or large data sets that could figure out exactly what was going on. So having those observations, having that qualitative data, and then quantitative in terms of turning that into numbers, was extremely helpful in terms of bringing that to the decision groups, so that there was actually a rationale that could be looked at, audited, and be used to drive the decisions. Carpedia really gave a great framework or scaffolding to the project, starting with those observations, starting with the messaging, and working closely with some of the sensitivities that we had as an organization. Carpedia was particularly skillful and useful to us in terms of building the internal expertise to continue the project after Carpedia had exited. So we were able to transition from a beginning of a project where Carpedia did the observations, presented the findings to management, helped us launch the project, do some training. We sent a number of our internal staff to Carpedia College for training, and now we actually have used that group as the beginning or kernel of an operations support department, which is really our internal consulting group within Yale-New Hospital. And it's been now extended to do other projects beyond Safe Patient Flow. Began a project which was really Safe Patient Flow 2, if you will, called Transforming Patient Care, which looks at, which has an overall goal of returning 60 minutes per shift for every nurse back to the bedside. And that launched about 1.5 years after the Safe Patient Flow project launched, and has also been quite successful. Even today, one of the real eye-opening parts of this Safe Patient Flow engagement was how many departments actually had to be directly engaged in order to accommodate our goal of reducing that bulk of patients that clogged the institution during the middle parts of the day. And it was really from the very beginning a multidisciplinary approach where every department head, from radiology to emergency department to express admission service, post-operative care unit, inpatient units, every single department head had a part to play in this. because safe patient flow for us turned out to be not one or two choke points, but multiple choke points. And every department had a role to play in improving our objectives. Well, anytime you undergo a process change, there are always multiple small hardships. I think the only large hardship institution-wide was the overall change process in managing we used to do it this way and now we're going to do it that way. By turning this project, which began life many, many years ago as an 11 a.m. discharge project, or as a ED overcrowding project, or as a reducing ED walkout or length of time that patients spend in the PACU project, but putting an umbrella over it and calling it a safe patient flow project, and putting that emphasis on two things, the patient and safety, I think helped overcome a lot of those barriers. That plus the fact that we were able to get some very quick early wins, which the staff very much felt that patient flow seemed to be going easier, that there seems to be a decrease in the barriers to communication and transitions and handoffs. And celebrating those early wins made the future changes much more easy to weather. And we front-loaded the project with some easy changes, and that later on, when we had to make some more difficult changes, people realized that this was for two important reasons: to make their life better, and more importantly, to make the patient's experience through the institution more comfortable and safer. All of our numbers have gotten better. We've gone from a census in the mid to high 700s routinely to a census in excess of 900 on an almost daily basis in the past couple years. And yet our length of stay hasn't gone up, it's gone down. Our 11 a.m. discharge rate hasn't gone up, it's gone down. So I think there's a large number of metrics we can look at, all of which I think tell a very good story about our Safe Patient Flow project.